brain dead criteria. But they can be declared by cardiac criteria, which is essentially the cessation of circulatory activity. And so the typical process for these is that a patient or a donor's family consents to donation of organs for transplant. The patient is then withdrawn from life support, meaning they're extubated, they're taken off any drips. And once their heart stops, a third-party physician, someone not involved in the transplant procedure, declares them dead. They look at the EKG, they listen for heart sounds, there's no blood pressure, and then the patient is declared dead. There are reports of circulation starting again in a short time after cessation of cardiac activity. So there's a mandatory standoff period, which is currently 5 minutes for most transplant programs. If there's no resumption of cardiac activity at that point, the procurement starts. And prior to 2020, the procedure was typically done, whereas a median sternotomy and a laparotomy is performed, all of the organs are taken out and put on ice. And so this, I think, kind of meets the definition of death after by circulatory criteria, all the organs are transplanted. In more recent times, there's been this advent of a procedure known as NRP, normothermic regional perfusion. Get mouse to advance. So NRP is a process where instead of directly procuring the organs, the patient is placed on a version of ECMO or cardiopulmonary bypass. So the organs are resuscitated in vivo. This is very similar to what we do every day for any cardiac procedure. The heart is massaged, defibrillated, and in most cases comes back. Patient's circulation is restored to the organs that are of interest for transplantation. Patient is then weaned from bypass or ECMO, not necessarily decannulated, but all the organs are assessed, and then transplant proceeds in the kind of the usual manner. So the heart rested with a cardioplegia solution, as are the lungs, the kidneys, and liver, and everything's transplanted like normal at that point. This raises some, I guess, more ethical concerns, simply because the organs are resuscitated. When this was first reported, a variety of people have interesting opinions about it. My mother called me and said, well, if you just restarted the person and the dead person and then use it in someone else, why don't you just restart it in the dead person? They won't be dead anymore. And I think it does highlight some of the issues that people bring about with this. There are some significant benefits of NRP relative to DCD with direct organ procurement. So there's very clear evidence that both the kidney and liver have better graft function when they are procured using NRP as opposed to direct procurement, where there's a prolonged ischemic time. There's anecdotal evidence that that's true for the heart as well. And there's demonstrated improvements in graft and recipient survival, again, for liver and kidney, simply because these have been done longer. And again, anecdotal evidence that that improves for pancreas as well. There's only a few programs in the country doing NRP and heart. So the data is a little bit early at this point. Obviously, this brings about one of the major questions of transplant, and that's the dead donor rule. The dead donor rule states that a donor must be dead before procurement and that the procurement must not cause death. And so the issue of resuscitating the patient or the organs in the donor, I think, is a little bit questionable. So I'll end with a couple of scenarios or questions to ask that may, I think, lead to the rest of the discussion. So, I think we all think we understand when a patient is dead, but let me pose a scenario that you are in the CCU and you have a patient under your care who arrests, and you resuscitate the patient to the best of your ability, CPR for 20 minutes. And at that point, you declare, this is unsurvivable. We have not had a return of rhythm, so I'm declaring the patient dead. And meanwhile, someone from CTICU walks by and says, you know what, we just started an eCPR program, and we can put this patient on ECMO at this point. and potentially get them back. And so what is the right thing to do? The patient's been declared, someone's looked at the clock and said time of death is X, Y, and Z. Is it appropriate for us at that point to put them on ECMO, knowing that the patient's been declared dead? And if we are to do that, do you have to then rescind the declaration of death, or do you have to say, well, we should do it because maybe we haven't done everything we possibly could have? And then if we do put them on ECMO and they recover, was that original declaration of death invalid? I think that's that leads to what NRP may look like. But let me also describe what we do these days for DCD procurements. So we're able to take a heart out and it's perfused and loading and working outside the body. So the whole concept of irreversibility of cardiac death, I think, is something that may be illogical in the current era. Right. Thank you. I look forward to the questions coming forward.
Thank you so much, Jay. Really appreciate that. I'm going to take a step back now and continue what I'm hoping is a little bit of mind bending that everybody is dealing with. I love that example that you gave of the CCU and the CTICU and the advent of eCPR and the other things that we're able to do. But let's take a step back and maybe fill out or begin to explore a little bit of what death actually means. And I have to admit that I don't think I can express the ethical issue any better than Jay Paul's mom did in all of this. So we should probably keep that as our sort of standard. You know, it's said that there are only two things that are certain in life, death and taxes. And as you can already figure out, we think maybe it's only taxes at this point. So let's go back to a brief history of death. How is it that sort of in ancient times we defined death or actually discovered that someone's was death? Well, actually it was putrefaction. And that's why we had these charnel houses where you'd actually put the comatose or dead body in, and then you'd wait to see if there was actually decompensation. And once that happened, then you knew the person was actually dead. And this, of course, morphed into concepts like the wake, in which you wait for a certain period of time, laying the person or the body out, and everybody gathers around, and hopefully the patient wakes up. But if not, then you go ahead and bury the person after a period of time. Obviously, the ancient Greeks, as with everything else, were very interested in some of these definitions, and they really realized fairly early on that it was a little bit difficult to rely on neurologic criteria because you actually had psychiatric illness that could manifest as death, toxins, hypothermia, metabolic derangements, traumatic brain injury. All of these can look very much like the person is no longer communicating or interacting with the environment, much as would a dead body. And of course, we ran into other problems, even as we began to get a little bit better with figuring out that there are cardiopulmonary reasons for death. And there was a huge scare in the 1880s, particularly in the United States, because of course you'd go to the graveyard, you'd dig up, and on the inside of the coffin are scratch marks. So clearly there were mistakes in declaration of death, and this became a fear, a rampant fear among the population that we were actually burying alive people, and then they essentially suffocated in the ground. And so it's very interesting to read some of the things that they came up with. So there were escape mechanisms that were actually built into coffins. There are also poison pellets. So if someone realized they'd just been buried alive, they could basically do or if they moved, it would set off a poison pellet. And in some cases, they actually set up elaborate contraptions to decapitate the individual to make sure that death actually occurred. So they didn't experience this buried alive. And I put a picture of Edgar Allan Poe here because he, of course, wrote a very famous horror story about that. And it got so bad that there was actually legislation that went forward in New York State that was promulgated by the Society for the Prevention of Burial Before Death. And this actually was quite a big issue and went to the legislature in Albany. And part of what they did was to try to define death. And so they said it was the permanent cessation of respiration and circulation, purple discoloration, sort of getting back to the putrefaction idea. If you apply red hot iron and there's the appropriate or inappropriate amount of blistering, rigor mortis, of course, was a good criteria. And if you start to decompose, that makes sense. But of course, we had some problems with cardiopulmonary death as well. As we began to do CPR in the 16th and 17th centuries, we realized you can actually bring the heart function back. Ventilators and defibrillators started in the 1920s. And of course, now you can actually support the circulation, the respiration artificially. And so that person might be irreversibly dead by cardiopulmonary criteria, but they certainly don't look like it on the ventilator or if they've been defibrillated. There was this concept that was put forward by two French doctors in 1959 of coma dépassé, the sort of beyond coma, this idea that it wasn't something that person was ever going to wake up from. And then, of course, as Jay mentioned, we had transplant beginning to start in the mid to late 1960s, and there was great interest in neurologic criteria for declaring death at that point, because of course that would facilitate transplantation. This got to the point where a bunch of people got together at Harvard, promulgated the 1968 so-called Harvard criteria to try to define death by brain criteria. And in the 1970s in particular, there was some interest of going back and forth in the pond between whole brain death versus just brainstem death. And so you could be dead in Great Britain and not dead in the United States and vice versa. There were some issues with this too. One of which was most of the studies or most of the experience suggested that when you had brain death criteria, you would eventually have death by cardiopulmonary criteria. And that was the justification saying that you were dead by brain death criteria. So there's a little bit of circular reasoning there. Essentially, you are dead because you will die, and that will become important as we go forward. There was a sense of defining brain death, not just by the different criteria that we might have to measure, but also this concept, this global concept of irreversible loss of integrative function. Well, the problem is we know that there is still some integrative function that goes on after people are technically brain dead, particularly in the pituitary. And this sense of disintegration of personhood, this sort of taking a step back and saying, you're dead because you're no longer a person. Well, obviously that gets interesting when you're trying to define all of those things. And here's just some issues here. As I mentioned, the pituitary issue, and then what do you do with a brain dead pregnant woman who actually is still very much feeding the baby or fetus inside? How do you actually look at that? Is this person actually dead? Certainly by brain dead criteria, but there's signs of life and signs, in fact, of supporting a different life. And then what do you do with persistent vegetative state and anencephalic infants? There's questionable personhood in those cases, but dead or not dead. So really we're left with this kind of heart or brain and what we're actually going to be using in our what we think constitutes our diagnosis of death. So is it cessation of cardiopulmonary activity? Is it cessation of brain activity, however you actually define that? Maybe it's cessation of only some brain activity. And then how do we actually diagnose death? Well, we have all of these tests, and flat lines across the board seem like a good way to do that, or absolutely nothing going on inside the skull. But really, how do we actually do this? Is it the old way of the lack of pulse or spontaneous respiration, or some of our better ways of doing that? And brainstem reflexes have been sort of the tried and true way of doing this by physical exam and apnea testing. But really, lack of consciousness, does that play a major role in what's going on? And of course, now we have sophisticated ways of measuring cerebral blood flow. But then there's this question, as Jay mentioned earlier, about when we actually diagnose death. And that's interesting as well. Our traditional 20 minutes of CPR very much being challenged in the modern case, in which we have a lot more things that we can actually do, eCPR and others, in order to support and maybe even rescue. This sort of, now that we're actually rewarming people after cardiac arrest, we have to wait a requisite amount of time. I did an early study on this, suggesting that we were absolutely not waiting 72 hours to declare brain death after rewarming patients after cooling. Cardiac arrest, as Jay mentioned, is a major issue in all of this. But what about cardiac arrest in a patient who has stage 4 metastatic cancer in a DNR order? How does that play into the time limit on life that we are actually going to give? Or how about a massive intracerebral hemorrhage that doesn't necessarily meet brain death criteria, but let's be honest, the person's not coming back from this. And what about if that happened in an Alzheimer's patient? Starting to get more and more interesting. But then if we take even a step further back and actually, I think, begin to look at this also outside of the medical context, what actually is it that defines death? What shifts a human being from being alive to being dead? Is it a lack of sentience? Is it a lack of personhood, as we mentioned? Is it the sensation of all spontaneous biologic activity? Well, that would really be complicated. Pituitary and pregnant woman, as we already mentioned. What about the concepts of departure of the soul and when that happens? As you know, in many different religious traditions, this happens at different times after death. So this really raises the question, is death kind of relative? Is a person dead because we say they're dead, or maybe they're dead because they're going to die? And this brings in issues of futility that we have to think about. And there's all of these things that we use in colloquial expressions, as good as dead, dead enough, mostly dead, near death. It's kind of as what we're doing in many different ways, even in the medical context. And of course, as Jay mentioned, there is this thing that's actually called in the medical literature the Lazarus phenomenon, the idea that a person could reanimate after a certain period of time after being declared dead. And hence we need that 5 minutes, gone down to 75 seconds in some cases, before you declare a donation after cardiac death person dead, because there is a rate of reanimation that happens despite our best efforts at prognostication and our ideas about what constitutes death. So there was a President's Commission on Brain Death that actually met in the mid to late 2000s. And they came up after considering all the stuff, listening to many different experts, exploring all of these different things. They kind of came up with this idea, first and foremost, that we still need a definition of death. And Denise is going to talk a little bit about the UDDA, and I'm not going to define that, so you have to listen carefully to what she says. But they really sort of reaffirmed this idea that, you know, death is not relative. We still need a standard. We still need to be able to declare death. And they sort of came up with this idea of disintegration of commerce with the environment, and they further subdivided as receptivity and drive and ability to act. And certainly this is still controversial as we have laid out. But those were basically the ideas that at least the President's Commission have come up with. The question remains, what are we going to do with death? How are we going to actualize death, if I can say that? How are we going to actually particularly apply it in this area of donation after cardiac death and normothermic regional perfusion? And thank God we have Denise to answer all of those questions for us.
No pressure. Okay, great. Good to see everybody. My voice tends to carry, so I'm going to try not to blast you. Okay, so the first thing I want to go through is the fact that there's a lot of things ethically that basically everybody agrees on. I can read this a little bit better. Okay. First, cadaveric organs are no longer useful to the deceased, right? If they can be useful to someone else, that's good. So they also, transplantation saves lives. So it can be good. It's a good thing to use them for that purpose. Respect for persons. So we want to respect both first person consents for donation. We also want to respect grieving families. And this can be tricky to do, but we all, I think, agree that those things are very important. We want to prioritize comfort and dignity in the withdrawal process preceding procurement, so that's the main priority, is that patient who's dying is comfortable and that process of dying is as smooth as possible for that person. We also want to reduce conflicts of interest that may be perceived or actually there. So that's where that standoff period. Oh, sorry. Thank you. So that's where that standoff period that Jay was talking about comes into play. And we also, all of us want to respect cultural and religious diversity and various different ways that people think about death and a donation, and make sure that that's a part of this. Now, I will say, when it comes to the notion of informed consent, there can be disagreement about how we respect persons under these circumstances. So an OPO might want to honor a first person consent while a family member is really grieving and is pushing back on that first person consent. And in both of those situations, we're trying to respect the people who could be suffering from the death of this person. And so a lot of ethicists, so there are ethicists that go both ways, but a lot of ethicists say one way to address this is to have a very full informed consent process for an NRP and other kinds of things so that everybody knows what's going on. So the act that Jim signaled I would be talking about is called the Uniform Determination of Death Act. And this is where in the literature and in fact, some of the tensions, we start to see some of the tensions between different concepts and notions related to death. So there can be, oh, sorry, now I'm on that wrong page. Okay. So we make a distinction here between permanent and irreversible. So that an individual who has sustained either irreversible cessation of circulatory and respiratory functions or irreversible cessation of all functions of the entire brain, including the brainstem, is dead. A determination of death must be made in accordance with accepted medical standards, which usually means declaration by a physician that the person is dead. Now, we make a distinction between permanent and irreversible. Permanent means we will not bring this person back. So those are these decisions with controlled DCD. We're going to withdraw treatment, life-sustaining treatment, allow the person to die. We could do other things that make them come back. We don't do that because it's not what the person wanted or the family wanted, and it makes it medically futile, right? That's different than irreversible. Irreversibility means it cannot come back, right? So that person cannot be auto-resuscitated or anything else. And this is where the tension lies. So some people, so the statute says irreversible, not permanent, irreversible. Some people say it doesn't matter, right? Permanent is the way that we should be thinking about this, because this is the intended effect of whatever directive the person gave us, right? And the sort of our goals of care. Others say we need to stick to this notion of irreversibility because of the slippery slope of what death could mean based on what Jim has just pointed out to us. So the other thing that comes up that, Jay, if we need explanation, I'll turn to you. One of the things that comes up is when circulatory death is declared, we understand that death is a process, right? It takes a little while for everything to sort of die. And so in NRP, normothermic regional perfusion, for the purpose of procuring these organs, in order to ensure that the brain is not perfused after circulatory death, there's a ligation of the arch vessels to prevent neurological perfusion, right? So that process can continue. So this raises a couple of concerns for some people, no concerns for other people. One, if that dead person who we declared as dead could suffer, then is that person really dead? Because it's the suffering we're trying to prevent by ligating those vessels, right? So are they truly dead, right? Have we allowed that process to complete? And then there's the other question about, is ligation the cause of death? Now, on the one hand, no, the person's already been declared dead by circulatory criteria. Legally, that's all that's required, etc. But under these unusual circumstances where it's really medicalized, that death, between death and procurement, you do have to ask the question, have the surgeons now taken an act with the intention of ensuring neurological death? Some people will interpret this potentially as something like euthanasia or euthanasia. We've taken a step that causes death. Okay, so just give you a little something to think about there. Back in, I think, 2008, there was a report in the New England Journal of Medicine about 3 neonates who, using controlled DCD, they procured hearts, and the ethics committee in this case talked about the standoff period, so that period of time between the declaration of death and the time that the surgeons are going to come and start the procurement. And here, they were giving heparin beforehand. And when circulatory function ceased, the first patient was observed for 3 minutes before death was declared, and the organ donation process was initiated. And then on the basis of a recommendation of the ethics committee, for the other 2 donors, the observation period was shortened to 1.25 minutes. Now, I didn't like this when I read this, because back to that notion of auto resuscitation, all the things that Jim was talking about, the 5-minute standoff period is a more, I think, responsible standoff period, right? Because it gives enough, it permits enough stuff to happen that it's less likely that somebody is going to have any problems or neurological sort of viability after that. But 1 to 3 minutes, I mean, and these are also neonates, so that obviously their bodies are a little bit more resilient. Another thing, probably one of the things that's the most important, so we as ethicists, my main job as an ethicist is to ensure that all of the ethical perspectives of those who are impacted by any cool thing that we think we're going to do are on the table, so that we can make the best possible decision about what to do, period. So my job is to, if I listen to the surgeons and they're making a really great argument about why we should do this, my job is to think about what might other people worry about under these circumstances, make sure we have all that information too. That means that we have obligations at UW Medicine and elsewhere to elicit the perspectives of people like, let's say, the perfusionists, the OR nurses, other people who will be involved in this, and then possibly also the public, those who would be the donors, right? So, and the one thing I think we can acknowledge is that some people might be intimidated to talk about any concerns that they might have, because the surgical team that they work with, this is like a family, they really trust each other, et cetera. And so part of my job is to make sure to elicit some of those different points of view, because conscientious objection might be relevant in this case. We wouldn't want someone to participate if they themselves personally thought it was wrong to participate. And then here, the hardest questions are always about justice and fairness. And so here we have utility, which is basically the notion of doing the most good for the most number of people usually. And certainly cadaveric organ donation and increasing the viability of the grafts meets that utility standard. But as we saw during the pandemic, sometimes utility, a commitment to utility, can have cannot address all of the equity issues. So here, for example, there's been a great increase in the number of African American, for example, or Black patients who are receiving transplantations. That's up on the left, and you can see also on the bottom right by ethnicity, different where donors are, right? Which ethnicity donors are. Now, if we wanted parity, something like utility, what we want to do is we want to see these numbers match a little bit better, right? So that we're not exploiting people who have been historically exploited by taking organs from them and giving them to people with more privilege, right? And over time, things are getting better, but we're all committed to making that better, even better as time progresses. And then the last big ethical issue is the allocation of resources. So in addition to ECMO, and certainly most importantly, staff time, especially in the circumstances we've been working in lately, and OR time, the question becomes, is this a good use? Is NRP and this intense utilization of resources a good use compared to what might be needed in a hospital or in a region, right? And here again, equity comes into play, right? What are all the different kinds of things our patients need from us, and where should those resources flow so that we are addressing disparities in care as best we can? So that's just a quick overview. And now I'll turn it back to Jim.
Thank you so much, Denise. That was incredibly helpful to set those boundaries, begin to look at some of the issues that all of this brings up for all of us. So now it's time for audience participation, because you got ethics just like everyone else, and we want to hear from you. So if you are online, please enter things into the chat. We definitely want to hear from you, and we have a wonderful audience here as well. We'd love to hear from everybody in the audience as well. And so I just want to open this up, but in a way, I also want to give everyone some questions to think about. and I put these up on the board to perhaps stimulate some of the discussion. But as you consider these, by no means feel that you have to address these. We're very happy to have you ask questions of us, in particular, if you have any mechanistic questions that Jay Paul can answer about how this actually works and his experience with it, and some of the experience of the literature as well as he has looked at it. By all means, please ask those questions. And I'm going to see if I can actually bring up the meeting controls, because I can't currently view the questions that people are asking online, but certainly we can get some help in doing it. But anyone here have any questions? And I'll go ahead and repeat them just while the mic is up here. Go ahead, Shinoso.
Well, morning. I think earlier on in the presentation, the point was made that the cadaveric organ is a dead person. To play devil's advocate, what about the counterpoint that that dead person's organ is needed to have the body fully intact?
So great point by Chinoso. We made the point that cadaveric organs are no longer useful to the dead person, but is that in fact true? What if being buried intact, for instance, from a cultural religious tradition is something that's actually important to the person? And I'm hoping I didn't butcher your question there, but Denise, do you want to take that one?
So I think, great point. You're exactly right. I would say one of the other ethical agreements was that we would respect people's religious and cultural preferences and ways of living in the world. And to me, that would trump that one. So it takes higher precedence than the fact that it would be useful to others, and we would make sure that that person had their organs when they were buried.
It's another great question, Jay Paul. I have to bring you up to answer this one. Do you offer support for the nurse that has to face the family and deal with all of these issues? Moral distress is a real thing.
I assume we're talking about the nurse taking care of the donor in this case. And well, the answer is no, not me. There is support from the OPO, which is Life Center Northwest in our area, to kind of facilitate and support all of the staff that take care of donors prior to the procurement process.
Absolutely. So I believe we have someone who would, can we unmute the person who would like to answer this question as well? Well, that was just me. I was considered, not me, Jay Paul. Very good. So anyway, sorry, go ahead.
Here's your comment on the stand talk time of 5 minutes in the pediatric case, and how you were a little struck by that time short. I wonder if there's some history around that time. It's like 5 minutes and round numbers seem arbitrary to an extent. And why is it 5 minutes? Why isn't it 4? Why isn't it 3? Where are those numbers really coming from?
So fabulous question about the standoff time. 5 minutes seems as arbitrary as 75 seconds. Where do we come up with that? How do we decide the right number? Jay Paul, why don't you answer that one?
So a lot of it comes from anecdotal experience with autoresuscitation. There's reportedly nobody that resuscitates in these circumstances after 90 seconds. So 5 minutes was felt to give enough of a buffer. But I guess to add to that question, does it even matter if the intent of the donor and the donor's family is to donate? Does that time period matter at all?
Great questions. Yes, Steve.
We're gonna have.
Steve, wait one moment. The mic is coming over, so I don't have to butcher your question by restating it. So that, excellent. Keep them coming in over the chat as well. We'd love to hear from you.
Now, it was brought up earlier, touched on briefly about the patient who wanted to donate, had passed away. They wanted to be a donor, but family members were not wanting them to donate. What does the hospital stand in terms of honoring the wishes of the person who has passed on over the family's desires?
That's a great question, Denise. This comes up pretty relatively frequently on ethics consultation, I can tell you.
Yeah, I wonder though, if you want to answer first, then I'll answer with the hard cases.
Oh, okay. We're gonna do the easy answer first from J. Paul.
So I see this for people that are very close to donation. And I don't know, in all the years, I've not been involved in any case where a procurement went forward when there was objection from the family. I have heard that there are such cases, but they're pretty uncommon. And I've never been in a situation where we've escalated it. We've always just walked away when we were there and there was questions.
So basically the wishes are not going to be honored?
Well, I think, so I will say just to back up Dr. Paul here. So the UWMC Montlake's position policy that we recently revised is that under those circumstances where there's a conflict but between the first person consent and the family, that the medical director would be involved to help kind of figure things out. Otherwise, the OPO sometimes can be very aggressive and assertive. And one way to think about it, so you're right, on the one hand, if we do, as Dr. Paul is talking about, it does mean that that person's first, that person's desire doesn't happen. On the other hand, because they're deceased, the people who are harmed are family members. And so you're trying to balance out, that person can't be harmed, they can be wronged in the sense that, yes, we didn't fully respect them by doing exactly what they wanted after they died. And at the same time, the suffering of the family seems to be high in our minds.
Yeah, this ends up in an ethics consult a lot of the time. And part of the questions that also come up are when people check that box on their driver's license application, have they really thought through this, or is this sort of the socially acceptable thing to do? Have they had a conversation with their family members? A lot of times the family members are blindsided. Well, I never knew that they wanted to donate their organs. We had never had a conversation about this. And so whether or not this was an informed decision does raise the question. And I feel bad for the poor driver's license person behind the counter who, well, would you like to donate your organs? And then, well, what do you mean by that? Well, they have no idea. They've probably received no training to counsel people in what donation of organs means. So on the one hand, it's wonderful that we have this social pressure or social influence to have people make a sacrifice like that and actually choose to donate. On the other hand, it's not entirely clear that they understand the implications and probably haven't thought this through or communicated with their family. Yes.
Can you speak to the spouse's family, knowing that some people live with domestic partners or like friends who are closer to them, whole family?
So great question. Definition of family. Is it people who are actually blood relatives, close friends, others? No, but Denise can.
So it certainly is anybody who they've designated as their durable power of attorney. And then it cannot, and then we're using the goodwill of those who loved that person to tell us who that family structure is. And sometimes, of course, there's disagreement among family members. That's another situation where you'd want ethics, other people to kind of help figure out what's going on there. So we don't want to exclude, by the use of the term family, that is not meant to exclude family members of choice rather than by birth.
Another thing that's worth mentioning is that differs by state. So in Colorado, it's all interested parties. So you don't have to be related and you don't actually have to prove of the relationship. You have some interest in that particular patient's outcome, you can be involved in the decision making, and other members cannot exclude you based on that interest.
Many states also have a hierarchy because ultimately you do have to have a decision maker. So they do list the people that are there, but that hierarchy is sometimes not appropriate, of course, because of the specific circumstances, and the hierarchy needs to be applied and interpreted. Bill.
Yes, a comment and a question. Recently, there's been the use of dead bodies as a test bed for medical devices. That's a sort of a reverse thing. Instead of donating an organ, you're using your body as a test bed. And that's going to be another level of ethical issues. But I'm interested, if you watch the patient go through the termination of pulse and respiration, are hearts donated under that situation less good than hearts received when a patient's been on a respirator and maintaining for instance, a cooling patient that ultimately donates a heart. Are those two sources of hearts different in their effectiveness at treatment?
So great question. I'll have Jay Paul address the second issue first, and then I'll give a little historical perspective on the first from my firsthand experience.
So there's only one good study, the DCD OCS trial, which came out earlier this year, and hearts from DCD donors are as good, if not better, than selected brain dead donors. I think the process of brain death harms the heart in many cases.
Yeah, it's been controversial, so it's good to actually have some data behind that. In regards of experimenting or practicing on dead bodies, I was actually in residency when we were all asked to fill out a survey about whether or not we'd actually ever been basically asked by an attending physician to practice something while after the patient had died. And so that actually happened to me during medical school. Patient died and during an intubation attempt by me, and it was not anything that I did. The patient was probably going to die anyway, but the attending thereafter said, all right, do it again, do it again, do it again, after the person had been declared dead. And I, being the young impressionable third-year medical student, followed orders and did as I was told. When I was in residency and we filled this out, that actually ended up as a New England Journal paper by Loris Calgin, who's a good friend of mine, an ethicist who was at Yale at the time, is now at the University of Iowa. And it was very, very controversial when that came out, but showing that I think well over 50% of us answered yes to that question led to many hospitals outright banning that activity. So I think some of the younger people in the audience probably say, I can't believe that was even a thing because we would never do that now. Well, the reason you would never do it now is because of work by Loris Calgin showing that it was very common. In terms of experimentation, that used to happen all of the time too. But really, it's now recognized that is not respectful to the family members who never hear about it or to the patient and the patient's memory. So this is something that has, I think, been roundly criticized and banned. But I don't know, Denise, so does this still pop up every now and then?
Not to my knowledge, but I'm sure it's out there somewhere.
Yeah, probably still happening somewhere, but not that we know of. Other questions or issues? I hope I'm not missing anything in the chat either, because I'm not actually able to see that. Oh, I'm sorry. There's the chat, and there are no open questions. I'm sorry, but Greg, do you have a question?
Yeah, I mean, absolutely fascinating talk. Thank you all. And I think I want to come back to this question of maybe this trial and the evaluation of the donor heart. It may be that these hearts don't go through the physiologic changes that someone, that they would be exposed to if it was a brain death patient, but it's also patients who are a completely different population than those that we're traditionally harvesting from. And I'm curious about your thoughts on the comorbidities and other conditions that these donors are in terms of infection, renal failure, as opposed to what is not always, but often younger trauma patients who otherwise have functioning other organs. Is there going to have to be a change, or are there any discussions of changing the evaluation of donor hearts? And what's the discussion with the recipient like as you talk to them about what's essentially a different population of donors?
Sure. So I think the first part's easy. They're different donors, no question. The criteria is a little bit different. They tend to be a little bit younger. And you also have the group of people that don't expire in the 30 minutes that we have set as our criteria. And so they're going to be less injured with the procurement process. And they obviously will have a very severe neurologic injury that causes them to stop breathing rapidly. And they usually have lung injuries, so they become hypoxic faster. So you're right, it's a different group of people and it's more selected than the brain dead donors. So maybe it's not apples to apples, but at least we're comfortable that if we use that criteria, the donor heart is as good as if we use normal brain dead criteria. The other question about donation and the disclosure to recipients is one that Denise and I had talked about recently. And what we settled on was if there was a meaningful difference in outcomes, yes, require a separate consent. And if it did not, then it would require information, but no longer a separate consent. So the model that we used was what the abdominal transplant team does. The kidneys from deceased DCD donors have the same outcome, so they have no separate process other than informing the recipient, whereas the livers have a higher incidence of biliary complications, and so that requires a separate informed consent that they're getting a DCD organ. And so we've done the same for the hearts.
I would say for NRP, I think I'd want more information shared with the family when that's involved. So DCD is one thing, but with NRP, I think it's a little, I think we want to share a little bit more.
I'm curious, globally, programs around the world that are doing transplantation, what our modern spectrum of definitions of death are, and have they changed significantly and gotten closer together, or is there still some variability?
That is an amazing question. I don't know the answer to that.
So that 2008 paper that Denise put up, essentially the uproar over that essentially stopped DCD heart donation in the US for the next 10 years. However, in the UK and in Australia, that work continued on it. And the resurgence of DCD hearts in the US was due to the reports from both Australia and the UK that this is feasible and considered ethical in those circumstances.
Great point. Any other questions?
So slightly broader question. What's the biggest barrier to getting a program like this up and running at a place like you?
Or DCD?
Yep.
There is cost. Resources like Denise talked about, DCD with direct procurement, meaning you take it out, then you put it on ice and you bring it, as described in 2008, is not considered viable for adults, for adult donors, like it is for children. So we have to use this OCS device, which is very costly. And then for NRP, you need to take a team of usually 2 surgeons, technicians, perfusionists, all your equipment. And so the human and capital resources for DCD thoracic procurement is pretty sizable.
All right. Well, I do want to bring up one other ethical issue that I think we have to, I'll leave you with this since we're sort of almost out of our time. And that is the issue when we have these resuscitation techniques of really the intent of what we're actually resuscitating patients for. You know, I think it is worth sort of asking this question about how we use our resuscitation techniques. And for the most part, we have conflicts of interest, right? We certainly have the larger society, we have individual and minority groups that are going to be impacted by this. I'm thinking in particular, there was an uproar in New York City over a sort of was a procurement mobile, but got called the death mobile. It would frequent areas in Harlem where there were gunshot victims and people would immediately be put on extracorporeal circulation and then transported to the hospital for the purposes, presumably, of actually being able to donate their organs. And so really, are we potentially moving from a presumption to treat to a presumption to actually harvest? We have to sort of make sure that there are ethical safeguards as we move forward in this. But as Denise mentioned, the upsides to this, particularly as we're thinking about all of the things that we can do for patients and what we can afford society, as long as we actually have all of our issues in line and have thought through this very carefully, I think we actually have a lot of potential for making a huge difference. Just personally, I'll tell you, I was a little uncomfortable with the concept of DCD when it just came out. But then I began to realize that this is a gift. It's what people are deciding to do on behalf of others. And that has to be weighed into some of the ethical considerations of this. But I absolutely want to thank Jay Paul for his willingness to involve ethics really from the get-go in this whole process. Not everybody's excited about having ethicists come in and comment on what you're doing. And Jay Paul, and I think everyone here has done a phenomenal job of wanting to get this right. And I think that's something that we need to pat ourselves on the back for, particularly Jay Paul should pat himself on the back for, and we all should pat his back for, because this is actually important. And as I think we saw from our wonderful comments today, we definitely need to keep wrestling and thinking about this as we move forward. Any last comments? All right, I think we're right at time, and I want to thank the audience and everybody online as well, and thank Greg for the opportunity. We really appreciate being able to come up and kick the year off in this hybrid style, and we'll look for a absolutely wonderful Grand Round series this year. Take care.